students, hope you have gone through the 4 previous PPTs in Cornea Basics. They form the background or they form the foundation on which the corneal diseases, we have yet another 4 PPTs on corneal diseases, will be built on. So if you aren't sure with the previous 4 PPTs, I'll sincerely urge you to go back to those 4 Cornea Basics PPTs and be thorough with them before venturing into corneal diseases. So the first and foremost and the most important disease of cornea, which from the exam point of view also is very important, it's a full long case for you, is corneal ulcer. Corneal ulcer is a big problem, especially in agrarian economies like India, where most of the people live in rural settings and have agriculture as their main occupation. The amount of injuries to the cornea and subsequent development of corneal ulcers is profound. So when you think of corneal ulcer, the first point I want you to focus upon is the risk factors. The risk factors are trauma. First is trauma. In fact, corneal epithelium is very protective, very protective. To penetrate a corneal epithelium and enter the cornea and affect the cornea, only 1 or 2 organisms have that much of virulence. One is gonococcus, and another is Cornebacterium diphtheria. These 2 organisms can penetrate an intact corneal epithelium. They don't need a corneal injury per se to affect the cornea. But other than the 2 organisms, most of the microbial flora needs corneal injury. The corneal injury can be so very trivial. It can be just a fingernail injury. It can be an injury during an industrial work. It can be injury in the agricultural fields by a thorn or a husk. It can be an injury by children when they are playing with each other, the bows and arrows. Any kind of trivial injury in the eye is very dangerous. More so when it is not treated properly or when it is not attended to properly. Most of the time, if you see people having injuries, will wash their eye with the dirty water. Whatever water they get at that point of time, they wash their eyes with. And most of the time, that is the culprit. More than the injury, the water, the infected water which is used to wash their eyes is the main culprit which causes most of the ocular infection. So the first and foremost is corneal trauma. The next important thing is eyelid disease. The eyelids are very important as a wiper. We said, no, the lid reflex. Lid is a protective structure for the cornea, and the lids constantly close and open and coat the tear film over the cornea and keep it moist and away from injuries. And that doesn't happen in, say, lag ophthalmos. In, say, lag ophthalmos, the profile will be like the patient is having an inability to close his eye. So when he is even sleeping, his eyes are open, and because of that, the eye gets dry. And because of that drying, lot of infection sets into the eye, and that leads to exposure keratopathy. Exposure keratopathy is a form of corneal damage due to lag ophthalmos, which later becomes secondarily infected and becomes a full-blown corneal ulcer. So that is the problem with eyelid diseases. Similarly, ocular surface diseases. The ocular surface is a very fine and very refined surface. Any small aberration or any small, even a suture, if they have done a ECC surgery and left one suture, and that one suture is irritating the cornea, the free edge of the suture is irritating the cornea, it will lead to corneal injury and secondary infection. Tear film dysfunction. This we have covered thoroughly in the last PPT on cornea basics. We said that the tear film is the most important nourishing and cleaning and coating layer of the cornea. So if the tear film is not going to be proper, then the cornea is going to suffer. Any local or systemic diseases like diabetes mellitus, uncontrolled diabetes mellitus, lepromatous leprosy, lepromatous leprosy, sarcoidosis, collagen vascular diseases, all these will be affecting the cornea. Contact lens use, any patient who develops, who goes very erratic with contact lens use stands the chance of becoming infected, and that's developing a corneal ulcer. In fact, any corneal ulcer, when it is not healing beyond 6 weeks, a corneal ulcer is not healing properly, then you'll have to reevaluate all these risk factors. You have to see them first down initially itself, and then if they are there, then these have to be treated individually before treating the corneal ulcer. So at the outset, I wanted to make you understand that there are so many risk factors that affect the cornea, and they need to be addressed very thoroughly when you are dealing with corneal ulcer. Now coming to the symptoms and signs of corneal ulcer. A corneal ulcer patient will report to you like this. The corneal ulcer patient will report with so much of lid edema. He will have circumcorneal congestion. He'll have pain. Pain will be the presenting complaint, more so in certain infections. We'll see them. Certain infections will have more pain, certain infections do not have pain, but it is a primary complaint. Excess lacrimation. There will be so much of watering from the eye. There will be photophobia. The patient will come and tell you that he cannot see a light. Anytime he sees the light, he feels a painful sensation, and he goes for blepharospasm, where he tends to close his eyes. To avoid the light, he tends to close the eyes, and his vision is obviously bad. And if you closely notice this or see this under slit lamp, you will see this conjunctival and circumcorneal congestion. Circumcorneal congestion is more towards the limbus, and more happens in diseases of the anterior segment like glaucoma, iridocyclitis, corneal ulcer. You will get this circumcorneal congestion. Conjunctival congestion more happens towards the limbus, and this more happens towards the fornix, and this conjunctival congestion is more associated with the conjunctivitis. So be clear here itself. Conjunctival congestion is basically innocuous. It's more to do with something in the conjunctiva. Circumcorneal congestion has more to do something in the cornea or the anterior segment of the eye, and it is more dangerous. Okay. Next, hazy cornea. Needless to say, there is hazy cornea, and that hazy cornea has an epithelial defect over it. So what you see is a stromal infiltrate. These white sediments are there in the stroma, and above that, if you see closely, you will see an epithelial defect. That is why it is called an ulcer. An ulcer is basically an epithelial defect with an underlying infiltrate. This kind of corneal ulcer also develops a hypopyon. Can you see this hypopyon? Can you see? Nice. There is around half a millimeter of hypopyon, half a millimeter of hypopyon in the anterior segment of the eye, and you will see lot of corneal infiltrate, and this kind of presentation is very characteristic. If it is a very old ulcer, vascularization would have started. That is called pannus. Vascularization would have elicited not in a fresh ulcer, in a old ulcer. And if there is perforation, if there is some amount of thinning and perforation, the uveal tissue will prolapse out of the corneal ulcer area. That is a sign that the ulcer is very old and has perforated. So these kind of symptoms and signs, we have to be very thorough with corneal ulcer. Now, next important thing which I want you to know is like the stage of infiltration, the stage of ulceration, stage of regression, and the stage of cicatrization. So these are the 4 stages of corneal ulcer. So first, there is some epithelial injury. Because of epithelial injury, there is a stromal infiltrate. Can you see? Can you see the stromal infiltrate? This kind of stromal infiltrate happens. Once a stromal infiltrate happens, the epithelium will denude and then become an ulcer. Can you see? The epithelium is denuded and this becomes an ulcer. If the stromal infiltrate, if the stromal infiltrate is more, if the stromal infiltrate is more than the epithelial defect, it is a progressive ulcer. If the stromal infiltrate is less, if the stromal infiltrate is lesser than, if it is lesser than the epithelial defect, then it is a regressive stage. If the epithelial defect closes by scarring tissue, if there is a scar tissue which has formed here, there is a scar tissue which has formed here, it has formed a opacity. This is a stage of cicatrization. So these are the stages of the corneal ulcer. What is the causative organism usually seen in a bacterial corneal ulcer? Any organism. Staphylococcus, so pneumococcus, Pseudomonas, Neisseria gonorrhoeae, Escherichia coli. Any organism can be there. In fact, there are even special points with each other organism. If you suspect pneumococcus, then think dacryocystitis, because usually it is called Ulcus serpens. Ulcus serpens. Ulcus serpens is pneumococcus corneal ulcer, and it is usually associated with dacryocystitis. Pseudomonas will cause a corneal ulcer with a greenish yellow discharge. That kind of discharge, and it's a very virulent organism, so there will be profound pain and progression of the ulcer. Gonococcus is the worst. It is the worst organism. Yeah, we would have previously seen it in conjunctivitis, especially ophthalmia neonatorum, conjunctivitis of the newborn babies, where we said gonorrhea will be acquired by the baby from the birth canal of the mother, and this gonorrhea will cause so much of a fulminant infection that within 24 to 48 hours, the whole eye, cornea, conjunctiva, everything gets damaged, and the baby loses its eye forever. This kind of danger is there in Neisseria gonorrhoeae. Then comes the method of entry. The method of entry is usually by trauma. Very rarely will be there a circumstance where there is no trauma, yet there is an organism which has entered. Only organism that can enter without penetration is Cornybacterium diphtheriae and Neisseria gonorrhoeae. A bacterial corneal ulcer will be a very painful ulcer. Can you see the epithelial defect? This is the epithelial defect. And inside you can see the nice infiltrate. Can you see the infiltrate? And you can see the hypopyon here. The hypopyon. All these are present in a bacterial corneal ulcer. What do you do for this? We'll see again. How you investigate this, how you treat it, we'll see again. Now you have in your mind what are the stages of an ulcer and how a bacterial ulcer happens and what are the usual infective organisms. Next we go to fungus. In an agrarian society like us, exposure to fungus, which is ubiquitous, is very common. The common fungi which the people get infected is Aspergillus, Fusarium. Candida, you don't need to remember. Candida is mainly for immunosuppressed individuals. So in basically immunocompetent individuals, think of Aspergillus and Fusarium. What is the mode of infection? Any injury with a vegetable foreign body. They will say vegetable foreign body. That is most important. What is the characteristic hallmark? The hallmark is you will see a ulcer which has a feathery margin. Can you see? Feathery margin. A feathery margin. Okay, a feathery margin. And you see a ring. You see a ring around the ulcer. You see satellite lesions. A main infection is here, and there is a satellite infection here. A satellite lesion is seen. You will see small satellite lesions. Can you see the satellite lesions? The satellite lesions of the corneal ulcer. And you will see a thick cheesy hypopyon. There will be hypopyon in these patients. Hypopyon. The only interesting thing is symptoms will be more, symptoms will be less, and signs will be more. The signs of the corneal ulcer will be more. So signs will be more in a corneal ulcer caused by fungus. Patient will have lot of features when you see on slit lamp, but the patient per se will not be complaining much. He will not feel much of the pain, and that is the danger. Because it is not that very painful, patient doesn't seek medical care soon. He will wait, and that makes it to an advanced stage. Okay. The third interesting ulcer is an ulcer which is caused mainly in swimming pool infection. caused by a protozoa, and that protozoa can also be acquired by misuse of contact lenses. Patient uses contact lenses and doesn't clean it properly, or overwears these contact lenses, or uses homemade solutions for cleaning contact lenses. They will get this kind of an ulcer. This ulcer is like a central disc-shaped ulcer, which is very painful. That is the hallmark of this ulcer, pain. And if you do a scraping of this ulcer, then you have to use a chalcofluor white stain here. And culture is on a non-nutrient agar with E. coli overlay. So culture is done with a non-nutrient agar with E. coli overlay. The treatment of acanthamoeba keratitis is polyhexamethylene biguanides, and neosporin. Polyhexamethylene biguanides and neosporin is the treatment for acanthamoeba keratitis. Okay. So now, what are the complications of a corneal ulcer? If you don't treat a corneal ulcer, what treatment we will give, I'll tell you in the next slide, because it's a bit elaborate topic. But equally questioned and most of the times asked in the examination is, what are the complications of the corneal ulcer? The major complications I have given. One is iridocyclitis. Because the cornea is infected, the anterior segment also gets inflamed, and that is how hypopyon gets formed. And because there is an inflammation in the anterior chamber and there's a thick pus in the anterior chamber, the intraocular pressure will rise. And because there is a thinning of the corneal ulcer and destruction of the corneal tissue, there can be a descemetocele. Where there is impending perforation. And that impending perforation can go to a scarring phase, where even after scarring has happened, this is active phase, this is scarred phase. Even in a scarred phase, you will see that the iris coming and plugging the perforation. Once this descemetocele ruptures, it will get perforated, and once the perforation happens, the iris will come and seal that perforation. And that kind of sealing will happen in a case of a corneal perforation. Similarly, there can be a staphyloma, because even if this corneal ulcer area heals, it will not have that much of intrinsic strength as normal corneal tissue. So with the thinning, it will bulge. The bulging of the cornea is called staphyloma. Synechia is where it is stuck, other structure is stuck, iris is stuck on the cornea. Staphyloma is bulging of the cornea. Okay, staphyloma is bulging of the cornea. Certain times there can be a fistula. The perforation might be not sealed properly, and there can be a continuation of the anterior segment and the exterior. This is called a corneal fistula. There can be endophthalmitis. Endophthalmitis is where there is infection from the cornea, migrates to the interior of the eye, and develops a full-blown infection of the whole of the eye, inner chambers of the eye, and this leads to endophthalmitis. Corneal scarring is the final outcome, leading to a corneal opacity. Expulsive hemorrhage is one which I will discuss to you when we discuss cataract surgery, because it is of the same philosophy. The expulsive hemorrhage happens because of the same philosophy here and there. Here it's because of a sudden perforation. There it is because of a sudden entry into the anterior chamber by an instrument. So both we will discuss in corneal cataract surgery. Okay.